Hello, everybody. Welcome to another edition of Talking Away the Taboo. I am thrilled tonight to be bringing you Estie Rose, who is a genetic counselor from JScreen. These conversations that we're going to have tonight, this specific conversation and the one coming up shortly thereafter, tomorrow night, we're intending, is going to be all about genetic screening, genetic testing, carrier testing, etc. And we know that this is a deeply important topic to so many people in the Jewish community and the world at large, frankly. This is something that specifically the religious community has a little bit of a workaround for genetic testing and genetic screening. We're going to actually mention that tonight with Estie. Estie, I see you, so I'm going to grab you. Let me make sure that you're here. We're going to be talking about all of these things and really just giving you some of the mechanics. Tonight is about, hello, Estie.
Hi.
How are you?
Hello.
So tonight is about information. We're going to be getting into all the emotional pieces before. We've done some of it already. We're going to do it a lot tomorrow and through the next number of days. But tonight is specifically about information. And that's why we brought Estie. Estie is someone that we've worked with before. She is one of the most wonderful people at JScreen. JScreen has lots of wonderful people, but she's one of our favorites. So please introduce yourself and let's just get right into it.
Sure. So I'm Estie Rose, and I am a genetic counselor. I've been genetic counseling for the past 15 years, and I've been at JScreen for the last 6.5 years. I am from New York, and I've lived here my whole life. I did my master's degree and my undergrad degree here. Everything is here, and there's a lot of Jewish people in New York. So over the last 15 years, I've had a lot of Jewish patients. Yeah. So, I definitely would say that I have, quite a lot of experience in the Jewish community, doing my counseling for, reproductive carrier screening, for Tay-Sachs testing, and other conditions that can affect babies, and cancer testing as well, which I don't think we're going to address today, but genetic counselors deal with that too.
Absolutely. And in fact, I'm so glad you mentioned it. We are not going to be covering that in this conversation, but we do have a personal story coming from a woman in another couple of days who did specifically testing for cancer screening in regard to wanting to make sure that the embryos, that her children didn't carry that cancer gene. But that is a separate story. We're not going to talk about that tonight because I really want to stay focused on what we want to give to the community. So let's just dial this back a little bit and sort of give big picture, broad picture, right? So we know that in the regular world, in all of our bodies, there are genes that are, regular and typical genes and normal genes, and there are genes that are abnormal genes. And some of those abnormal genes are like normally what happens in our bodies, and they have absolutely no effect in terms of the way we function, the way we look, any kind of diseases or anything like that. I'm speaking with my medical hat, but I am not a genetic counselor. So if I get this wrong, you're definitely going to please jump in and tell me that I'm getting it wrong.
You're on the right track. So not all genetic variations or changes are related to disease. Sometimes they're just benign. Like you might have curly hair, I might have straight hair, right? That's due to genetic changes, but it's not always bad, right? It's not always related.
Correct. And so, but, or maybe the word is and, we do know that there are specific genetic changes that do lead to diseases or do lead to disorders. And there are a number of them that exist in the world that we have the ability in 2023 to test for. And so I think what I'd like you to start with is this idea of testing for disorders or diseases, what that means, and really the difference between what JScreen does and what a Dor Yesharim does. And I want to just, for the people out there who are listening to this who are not familiar with what I'm talking about, I'll give a small introduction and then I'm going to really let you take over. In many of the religious communities within the Jewish world, people know that genetic disorders exist because there has been a lot of intermarrying over the years, over the generations, over the centuries. And so we know that we as Ashkenazi Jews specifically, but also Jews at large, but specifically Ashkenazi Jews, have a higher incidence of a certain number of genetic diseases / disorders. And because this testing exists, the goal for people in terms of being informed, the goal for people is to ideally not have a child that has one of these disorders. And so what this institution,
Sure.
so Doria Sharim is the name of an organization, institution, I'm not sure what they are, which basically gives high school students anonymous genetic testing to see whether they're carriers of a number of specific genetic disorders. Now, the reason why I'm saying anonymous is because that's actually the crucial piece to the way they function, in that they're worried that if people knew that they carried this disorder, that they had this as part of their genes, that there might be a stigma in that family, there might be a problem. And so they make this testing anonymous. And so basically what happens in the community is that when two people are interested in dating, or when two people are interested in getting married, depending on which community you are, it depends on when you look into your results at Doria Sharim. Every student who gets tested has an anonymous number. Your anonymous number is fed into the system. The other person's anonymous number is fed into the system. It does its magic and basically spits back an answer that says, compatible, no problem, go right ahead, enjoy your life and get married. Or it spits back an answer and says, this is a problem, this is a problem. And then, so it doesn't specifically give any individual any information. All it says is you're good or you're not good. So now I'm going to stop talking. And I want you to give us more of an explanation as to what the difference is between something that JScreen does, something that Doria Sharim does, and in general about carrier testing, because that's really what we're talking about here. And now.
So there's a lot to unpack there. By the way, when Doria Sharim says not a match or incompatible, they don't just say this is a problem. They say we advise you not to continue with the relationship.
Right. So I wasn't sure if they did that. So that's why right. Okay.
This is how they started. This is how they always were. JScreen and other, more open testing models run a little bit differently, and we'll get into that in a moment. But I do want to say that even though we're different than Doria Sharim, we're all in it for the same cause, right? And the cause is to prevent diseases that could be devastating to a family. There are thousands and thousands of genetic diseases. Some of them are hereditary, meaning they run in families. Some of them just happen by chance. Some of them are so rare. So when we're doing carrier screening, we're not testing for every single thing. Some things you just can't plan for, they just happen. But we're testing for the common things that do run through families. And Doria Sharim is exactly the same. They're also testing for common things that run in families. These conditions are recessive. So in a recessive condition, when somebody's a carrier, that means that they are fine, they don't have any symptoms. But if their partner also happens to carry the exact same condition, every time they have a pregnancy together, there's a 1 in 4 chance or a 25% chance for the children to be affected with that condition. And each pregnancy is totally independent. So it doesn't mean, if you have 4 kids, 1 will definitely have it, the other 3 won't. It's totally independent. It's 1 in 4 per pregnancy. And that's the whole crux of carrier screening. We're trying to avoid carrier couples having children together without any advanced knowledge, right? So we're trying to figure out what are the chances for them to have a child who's affected. What I do as a genetic counselor is I counsel couples before and or after the results come in, and we talk about what they carry, because most people who are Jewish especially do carry things. So it's very rare for somebody to be negative. But we talk to them about what they carry and whether there's a high chance or a low chance for their kids to be affected with the condition. I did want to add to something that you mentioned before. It's not just an Ashkenazi problem. It's everybody. It's Ashkenazi Jews, it's Sephardi Jews, it's Mizrahi Jews, it's converts, it's people of mixed ancestry. anybody could be a carrier for anything. Some of these conditions are just more common in people of certain backgrounds. So it's not just the Jews who have the problem.
Thank you. Thank you.
Yeah, because I think there's a lot of misconceptions in our community about that. You know, I speak to a lot of Syrian Jews, a lot of Persian Jews in New York, and they all say, oh, it's an Ashkenazi problem. It's not. Some conditions are more of an Ashkenazi problem than others, but technically anybody could be a carrier of anything, and they're not exclusive to one, you know, ethnicity versus another. So everybody on the planet who is going to have a child should be doing carrier screening. It's always best to do the carrier screening before a pregnancy, because God forbid, if there is an issue and we do see that there's a, you know, at-risk couple, we'll give them more options. And, you know, that's what I do as a genetic counselor. So you can get tested by blood, you can get tested by saliva, which is what we do at JScreen. JScreen is an at-home testing model. So anybody in the United States could register for a testing kit on our website. The cost of the test is $149, and we'll screen you for 225 diseases. The result, you just ship it back to the lab, the results come into us, and then we let you know the results are ready. And then you'll have either a phone or a Zoom consultation with a genetic counselor such as myself. You know, JScreen is a Jewish program. We are run out of Emory University in Atlanta, but we are a Jewish program, and there's a lot of, you know, cultural sensitivity among all of our staff members. So, you know, we have patients from all, you know, all different walks of life, you know, coming in, and we are, you know, sensitive to everybody. When we have carrier couples, which happens every now and then, the genetic counselor is going to sit with you for quite a while and talk to you about what is the condition, what are your chances, you know, for your kids to have it, who else in the family needs to know about this, and what can we do with this information now that we know. With Dori Sharim, they don't tell you the results, as you mentioned earlier, so we cannot tell, or they cannot tell people about the condition. They cannot tell their siblings what they carry because they don't know what they carry. And as I mentioned earlier, they advise people not to continue the relationship. At JScreen and in most other, actually all other genetics practices, that is certainly an option. You know, we do tell people that they have the option not to continue the relationship, but we also provide many, many more options to them. And, you know, we do so with a very level-headed way of doing it. You know, like we just talk about the pros and cons of each of the different options because we don't really know people so well, right? We just met them and we don't know where they're coming from. We don't know what resources they have or what, you know, halachic or ethical concerns they might have. So we just lay out all of the options, the good, the bad, you know, about every single one. And we kind of just let them decide for themselves. We would never tell them what we think they should be doing.
Okay, so just because you keep mentioning it, and I think it's important to kind of segue into the next piece, what are the options? I mean, off the top of my head, I'm thinking you break up or you don't break up. Like that's basically option number one, right? Like, you know, if you choose you're breaking up, then you're not moving forward and you don't need to hear what the other options are. If you do choose to stay together, what are the options?
There are a lot. So as I mentioned earlier, it's always best to get tested before pregnancy because as you'll see in a minute, there are more options if you're not already pregnant. So some couples will decide not to continue the relationship. Some will decide to continue but not have biological children. Maybe they won't have kids at all. Maybe they'll adopt. You know, that's certainly an option. Some couples will decide to get pregnant and kind of roll the dice, and they can either wait to see until the baby's born and they'll know when the baby's born, or they can actually test a fetus during a pregnancy doing certain invasive tests like a CVS or an amniocentesis, where the doctor takes out some material from the pregnancy, whether it's amniotic fluid or placental material, and they can make a diagnosis. So during the pregnancy, you can find out whether or not this is a child who's going to be affected with the condition. If it's negative, great, you never have to worry about it for the rest of that child's life. If it's positive, you know, a couple like that would have two options. They can either continue the pregnancy with the knowledge that this is going to be a baby who has the condition, and they can prepare for it. They can read up on it. They can meet with specialists. They can, you know, try to use the rest of the pregnancy to learn as much as they can so that they can, you know what's coming. And other couples might decide to terminate an affected pregnancy. And, you know, I'm sure you know there's a lot of legislation going on now, and it's not always an option for everybody. And depending on where you are and how far along you are, there's so many nuances to it. But it certainly is, you know, an option for many couples. Other couples might decide to use assisted reproductive technologies. So they might use an egg donor or a sperm donor who's not a carrier, obviously, of the condition of concern. But probably the most popular or the most widely used option within this category is to undergo IVF or in vitro fertilization, where they would basically just test embryos to see whether or not they have the condition. This is called PGT-M, or pre-implantation genetic testing for monogenic diseases or diseases that are caused by one gene, like Tay-Sachs or cirrhosis.
Okay. And so, and there is PGT, hold on. No, I just lost it. Okay. I know there's another version of this because I know that PGT-M used to be PGD, but we're gonna go through a couple of things. So
yeah.
So the old name for this used to be PGD, pre-implantation, I can't even say the word, pre-implantation genetic diagnosis. That used to be what you're talking about, where basically you would test the embryos for that specific disease, and then the embryos that were affected would be embryos that you would not use, and you would only use the embryos that were healthy.
Exactly.
Correct me if I'm wrong.
No, you're correct. Just before that step, like to get to the embryos, a couple would have to undergo IVF or in vitro fertilization, the exact same IVF as a couple with fertility problems might undergo. So the woman just to simplify it a little bit, the woman gives the egg sample, the male gives the sperm sample, they let it fertilize in the lab, and they create an embryo in the lab. They let that embryo grow for usually about 5 days. And then on day 6 or day 5, that's when they have the embryo biopsy, or the part where they take out a tiny, tiny bit of the placenta, of the embryo, and they send off those couple of cells to the lab, and then they can check to see whether or not this is an embryo that's affected. While the results are pending, they'll freeze the rest of the embryo that was not used, and hopefully it could be used later on. If they see that it's an embryo that's unaffected, great. They'll take that embryo, they'll continue the whole process, and they'll implant it into the woman's uterus, and hopefully it will take, right? Hopefully it will become a successful pregnancy, one that is free of the condition. If they see that it's affected, 25% chance, they'll discard it in the lab. It would never turn into a fetus. It would never turn into a baby. It's pretty incredible.
It is, the technology is absolutely wild. It's truly miraculous. It's truly miraculous. Okay, so there's that, but there is also and the way they test it, and just to be clear, the way they're testing specifically for that gene is they make a specific genetic probe. There's a specific marker, let's call it, like I'm trying to use non-medical terminology here. I'm going to leave this all over to you because you do this more times a day than I do. But they make something specifically in the lab to make sure that they're targeting that specific piece of where the problem is. So just explain that part for a second.
Yeah. So not everybody who's doing testing or doing IVF does PGT-M. You only do it if you know there's a high chance for a baby to be affected. So let's say you did carrier screening and you found out you're a Tay-Sachs carrier couple. You know your mutations, the mom's and the dad's mutations. Those are the probes, let's say, that they need. They need to know the parents' mutations when they're doing the PGT-M, when they're doing the genetic testing. They basically look to see, does this embryo have mom's mutation and does this embryo have dad's mutation? So you can't do PGT-M unless you know both mutations, and you can only know both mutations if the parents first did carrier screening. So so it's not for everybody. It's only for people where we know there's a high chance that something's going on. It could also be used for BRCA, which again, I'm not really talking about, but I'm going to mention it anyway. For pretty much any monogenic genetic disease, which is a genetic disease caused by a mutation in one gene only, you can do PGT-M for pretty much any monogenic disease. Pretty cool.
Okay, which is amazing. And now somebody's asking here, this does not rule out disease 100%, correct or not correct?
No test is perfect. Anytime somebody undergoes IVF with PGT-M, we always recommend that once they're pregnant, hopefully it leads to a pregnancy, but once they're pregnant, that they test the embryo, the fetus during the pregnancy, doing one of those tests that I mentioned earlier, usually a CVS, where the doctor takes a needle, puts it through the woman's belly, and takes out a teeny bit of the placenta. Whatever is going on in the placenta should reflect what's going on in the baby. So it's a way of getting baby cells without actually touching touching the baby. And that would be a confirmatory test. You know, that would just be like another test just to really make sure that everything went right with the IVF. But
right, and I think this piece is important because a lot of people do think that, you know, doing IVF with PGT-M, or what I used to call PGT, they think it's 100%, that everything's going to be fine. They do that and it's going to be 100% fine. But because there is this small likelihood that this cell, correct me if I'm wrong, but the cells that they're taking out might not be a cell that's affected because there's still some mixture of cells. Is that the reason why there can be a difference?
Yeah, it's very
yeah.
Mosaicism, when there's two different cell lines in a person or in an embryo. It's very rare, but that's exactly why we say, like, just double check, you know, once you're already pregnant, just to really make sure that everything is in line with what we thought it was.
Right. So I want to emphasize that for everyone. Estie said, it's very rare. It's very rare that this happens. That's why they suggest doing the double check, but it is a possibility. So we're just mentioning it.
In medical world, you know, like, mistakes happen, but it's so rare that, I mean, I don't know anybody who chose not to do IVF because of that particular fear.
Yep. Okay, so now move us on to the general general genetic testing that people do when they are, like, when people are going through IVF. Like, often there is, like, there is the question that the doctors ask and the clinics ask. They say, do you want to have your embryos tested? Do you just want to implant them and see what happens? And in previous years, in many previous years, there was never even an option to test those embryos. You just, like, if it looked good in the lab, if it looked good under the microscope, they just thought, oh, okay, it looks good. The cells look beautiful. They're like, you know, this one is blonde, whatever. I'm just kidding. And they're like, oh, this is a beautiful looking embryo. This must be amazing. And so they would implant it. And the reality is that just because something looks beautiful in a little petri dish doesn't necessarily mean that it's actually genetically beautiful. And so there is this testing that's now being offered.
Yeah.
So Estie.
That test used to be called PGS, or pre-implantation genetic screening, where they would screen embryos. Now they're a little bit more specific with the terminology, and they call it PGT-A. So before, with PGT-M, we're checking for a monogenic, one gene. This is PGT-A. A is short for aneuploidy. So what is aneuploidy? We all have 23 pairs of chromosomes. That's normal, that's typical. Aneuploidy is when somebody has a different number. So they either have extra chromosomes or missing chromosomes. The chances for somebody to have a baby with aneuploidy does get higher and higher with maternal age. So as moms get older, the chances for them to have a child with Down syndrome, that's an example of an aneuploidy. Trisomy 18, trisomy 13, that's when they're extra chromosomes. So nowadays, you know, when somebody's undergoing IVF, we offer them, while we have the embryo sitting in the lab, maybe we can do the exact same thing as we did with PGT-M, take out a little, you know, a couple of cells from that embryo and check the number of chromosomes, check for an aneuploidy. It's always better and more beneficial to only implant embryos that have a normal number of chromosomes, not ones that have aneuploidy. Those embryos that do have aneuploidy are more likely to miscarry. They also might not even implant in the first place, so it might not even lead to a pregnancy. If it does lead to a live birth, so if the baby makes it through the pregnancy, it's going to be a baby who has, you know, serious challenges. So you're going to maximize your likelihood of having a healthy pregnancy if you do PGT-A before you implant the embryo into the uterus. You know, sometimes people will do it if they know that, if the doctor knows that they've had multiple miscarriages, maybe it's because there's some kind of aneuploidy going on in the family. You can use it for gender selection. That's another story. But there are excellent reasons for people to do PGT-A when they're doing IVF. It just, you know, one way to make the likelihood of a successful pregnancy even higher.
Excellent. So that's exactly what I really wanted to hear. I think these were the major questions that people were coming. They really just wanted to understand the process. They wanted to understand what the possible tests were that they could do. And I think, you know, this other idea about, like, what does it mean when I'm a carrier? What does it mean when I'm not a carrier? What does it mean, you know, to go through this testing? Am I assured that I'm 100% going to have a healthy baby? And look, we're not going to be able to cover everything tonight. That's not what this was intended for, but this was more intended to give everyone really just an overview of the process and to have a basic understanding when we're having these discussions about genetic screening and genetic counseling and carrier testing. This is really what we're talking about. Did I forget anything? Is there anything more that you want to add here, Estie?
I think I got everything in except for one point that I just wanted to add about carrier screening in general. I already told you anybody should get tested regardless of their background. I've already said many times that it's always better to do it before pregnancy versus when you're already pregnant. But one thing I kind of wanted to, one nuance I wanted to add to that is if you had testing many, many years ago, and now you're planning for a pregnancy, it's very, very likely that our testing panels have improved since the first time you were tested. And you're a carrier for something, whether you know it or not, right? So I believe, and I would think all genetic counselors would agree with me, that it's best to have the most up-to-date testing before any pregnancy. So even if you already have 1 or 2 healthy kids, just check in with us, you know, check in with anybody and see whether or not your testing is up to date or if it's totally out of date. And if it is out of date, we would recommend that people get retested. So make sure that you're up to date before any pregnancy, not just your first.
Absolutely. And I think that this is specifically relevant for people who are having kids, you know, into their 40s, right? That they're, or maybe haven't even started having kids until they're into their 30s or 40s, but you've had genetic testing or you had Dory Sharam done when you were young, like when you were in high school or you were in your 20s, and yet you're still having kids or embarking on, you know, adding to your family, et cetera. At later stages. I think that's an excellent, excellent point. Like technology changes all the time, and we are constantly adding new diseases, new disorders to these panels. So, I mean, if you're a person who wants to know, and that was something that you did initially, then absolutely, you should definitely do it again because you want to be armed. You'd rather, you know, everyone decides for themselves what they'd rather know. Would you rather know beforehand, or would you rather have to make a really hard decision or deal with a child who had a disorder? And you know, for every person that choice is different, but their technology exists now for people to know beforehand, and that's really incredible.
Yeah. We're lucky that we live in these times, you know, that we can offer so much.
It is an incredible gift. Okay, you know what? We do have a couple of more minutes, and even though I said we weren't going to get into the cancer testing or the BRCA testing, do you mind if we just touch on this to give people a sense of what this is and why it's important?
Sure. So BRCA is an example of a cancer gene. So we actually have many, many cancer genes, like hundreds of them. The BRCA genes are just 2 of them, BRCA1 and BRCA2. The job of our cancer genes are to protect our bodies from getting cancer. So we all have the genes. You have them, I have them, everybody on this live has them. But when we're doing genetic testing for cancer genes, we're not looking to see if you have them, we're looking to see if there's a mutation in them. I mentioned the word mutation before. A mutation is basically a structural change in a gene that makes it not work properly. It causes a disease. So if somebody has a mutation in any of their cancer genes, that's going to make that gene not work well, and it's going to predispose you to getting cancer. It's not going to protect your body from cancer anymore. There are a couple of genes that we know, a couple of cancer genes that more commonly will see mutations in people who are Ashkenazi. So the BRCA genes and a couple of other ones. And every gene is associated with different cancer types. So there are breast cancer genes, there are pancreatic cancer genes, there are colon cancer genes. So we're not going to go into each one, but the point is that when somebody tests positive for a cancer gene, a genetic counselor will sit down with them, tell them what their risks are for that specific gene, who else in the family needs to know because they're at risk as well, and what they can do with this information. So let's use BRCA as an example because it is more common in Ashkenazis. Women who test positive for a BRCA mutation have a significantly increased risk for breast cancer, up to 85%. Also ovarian cancer, up to 60%, and pancreatic cancer as well. Men can also have a mutation, and they would have an increased risk for pancreatic cancer, male breast cancer, and also prostate cancer. So when we talk about these risks, we tell them that each of their kids and each of their siblings and their parents have a 50% chance to have it too, so spread the word. And then we talk about what you could do with this information. So similar to our Tay-Sachs carrier couples, we have a whole list of options for them. We have the same thing for these cancer genes. For some people, it might mean having extra or more enhanced screening for certain cancers, like starting colonoscopies at an earlier age, having them more often than usual, starting mammograms at a younger age, and maybe also doing a breast MRI. So some kind of more enhanced screening than the average person might do for cancer, so that you catch it at an earlier and more treatable stage if it's going to happen. In other cases, we would recommend that they have surgeries, preventative surgeries. If you don't have a certain organ, it's very hard to get cancer there. So for example, in our BRCA positive women, we recommend that they remove their ovaries by the time they're 40 years old or by the time they're done having kids, because it's very hard to find ovarian cancer. So you don't want to catch it when it's too late. So it's better to just remove the ovaries so you don't have to think about it. These surgeries are a big deal, you know, and we don't take it lightly, but in many cases, life-saving.
They're life-saving.
Yeah.
But why are we specifically having this conversation now? Why are we, as a fertility organization, talking about IVF for genetic reasons? Why are we having this conversation now? Because
Okay, a few reasons. Number one, we mentioned earlier that if somebody wants to ensure that they're not passing down their mutation to their kids, they can do PGT-M, which we all know about now, where they can test to see, they can test embryos to see if they have the mutation, and if they don't, great, and if they do, they'll not use those embryos. Some women might also use it for fertility preservation. Right? So if we know that a woman is BRCA positive and she's going to remove her ovaries, she might first, before she does that, freeze her eggs so that she potentially could have children in the future using, you know, other technologies. It's really like, we're so lucky, as I was saying before, we're just so lucky that we have all these, we can have these conversations with people, and we can really, you know, save families from heartache. So J-Screen, by the way, we also do a cancer test. So in addition to our reproductive carrier screening, we have a separate test. Also, same idea, done with saliva. You have your genetic counseling, and we're testing for 63 different cancer genes. So if somebody has a family history or a personal history of cancer, or if they're just Ashkenazi and they want to know, or if they're not Ashkenazi and they want to know their risks, they can come through J-Screen, and we're happy to test them.
amazing. I look, I mean, now I'm going to say it now for the third time. We are living in a tremendous age of medicine where we don't just have to have things happen to us. We have the ability to be preventative about so many different pieces about our health. That have absolutely nothing to do with genetics, but here specifically in regard to genetics. And I really view this as being like exactly what, you know, Judaism says for us, right? The idea is, one of the main tenets of Judaism is we're supposed to keep our bodies healthy in addition to keeping our mind and our souls healthy. And one of the ways that we can keep ourselves healthy and also hopefully keep the next generation healthy is with these incredible tests. So I mean, that's the reason why you and I are having this conversation now. That's the reason why I think these conversations are super important in general. And I just thank you so much for offering your time and your expertise to all of us here. And again, I'm going to ask you one more time, what did we miss? What did we miss? Anything that is important for people to understand, to know? Oh, I actually know.
Yeah.
You might have something, but there's one more thing I wanted to ask you.
Yeah.
You mentioned both in regard to the cancer screening and in regard to the other screenings, about that you probably, if you know that you have something, that discussing it with other members of your family so that they could also know that they have these issues also, because then it affects their lives and their health and their future children. And I think that that's a piece that the Jewish community is scared of a little bit, that we're scared about, like, well, what does it mean if we have it and then this one has it and then we all have it and then we can't tell anyone? And then can you just speak to that, like the resistance of genetic testing that sometimes you see in terms of when people hear about it, how many of your patients or your clients, you know, will end up then, you know, having conversations with the rest of the family? What are their reluctances? Like, can you just speak a little bit about that?
Yeah, so I would say that I have a biased patient population, because these are people that are seeking testing, right? These are people who are knowledge seekers.
Okay.
So when we find, or when they find something out, they tend to share it with people because they see it as an important piece of information. I think where it gets very tricky is in the shidduch world. Not
And
so much.
just explain what that means.
So when some young Orthodox couples meet and by themselves, and some meet with a matchmaker through a matchmaker. And through those people who are meeting with a matchmaker, it's called a shidduch date, where basically it's a blind date. And in the shidduch world, the parents are very, very involved in making the matches. And they basically do tons of research before they even let their children meet each other. And part of the research is, how tall is he? How tall is she? What is she doing with her life? But in addition to that, very often they're going to ask the hard questions, like, do they have any diseases in their family? Oh, I heard the grandmother had breast cancer, or whatever it is. And when we know that there's something genetic, something hereditary running through the family, that can be like a big X on that girl, So if a girl is 22 years old, let's say, and her mom had breast cancer, she tested positive for a BRCA mutation, her chances are high, right? She has a 50% chance to have it too. And if she has it, that could be very, very difficult for her when she has to, when she's dating a guy and has to tell him like, hey, I have this thing, I'm very likely to get breast cancer one day. He's going to run for the hills, and that's what I've seen many times. So it's a very fine line, right? Because you want her to get tested because she should be safe, and it's important for her own health. But at the same time, a positive result could be very detrimental to her prospects. So the timing of testing for something as big as BRCA is very, very tricky. I see in the Jewish community that a lot of people ask their rabbis for guidance in this. Some people go with their rabbis, some people don't. So the sharing with young, men and women of marriageable age, that's when it gets tricky. But if it's, if a woman is 70 and gets tested and her brother is 65, of course he should get tested, because you're helping yourself, that's all you're doing. But it's a little bit less clear what to do for, somebody in their 20s or 30s.
Right. I felt like we couldn't finish this conversation with just mentioning the piece that there is, unfortunately, there is a stigma in the community in regard to, these genetic diseases or being carriers of a disease in the, matchmaking, dating, marriage world. There definitely is. We have to name that. We have to talk about that. But it doesn't mean that people shouldn't get tested for themselves. And again, timing and whatever, I mean, I'm in no place to recommend to people. That is not my role here. My role is to give information and help people make the best choices for them and for their families. Okay, I think there was something else that you also wanted to mention, or no?
I don't remember, but I definitely will, encourage everybody listening to find us online at jscreen.org. You can always send me an email. Ask me anything. I've heard it all. So anybody that I can help, I'd be happy to in any way that I can. And don't be scared. We're here to help you. We're going to walk you through the whole process. This is what we're trained to do. And we just want to make it as easy as possible for you.
Estie, thank you so much. This was incredibly valuable, really important information, and really just sets the tone for the rest of the conversations that we're going to have surrounding this. People need the information. We don't need people speculating as to, oh, maybe it's this, maybe it's that. No, it's like that. Like, we wanted the information, and I knew that you and JScreen were the right people to go to get the answers. So thank you so much. Everyone, again, I'm reiterating what Estie said. If you have any questions, personal, whatever, otherwise, please reach out to her, reach out to JScreen. They're happy to answer anything at any point. Okay. All right. Thank you so much again. And good night, everybody. Good night.